Hello and thank you for the invitation. I hope you heard and see me correctly. So first, it's an honor and really a pleasure to present you the role of radiotherapy in cranial meningioma. So I will just indicate the context, the evidence and limits of radiotherapy, some illustrating cases, and some messages. First, the context. There is an urgent need for us as radiation oncologists to choose a consensus in all these points: indications, doses, delineation, and techniques and fractionation, and hopefully also the particles, choosing the good particle. But sorry, I do not have definitive answers to all these questions. For example, even all centers in Swiss, it was a survey among 10 Swiss centers who were experts in neuro-oncology radiotherapy, especially for meningiomas. So for these all 10 Swiss centers, there was some indications who reached the consensus. For example, adjuvant irradiation after incomplete surgery in a recurrent situation with a patient with clinical symptoms, even for grade 1. For grade 2, after incomplete surgery, the majority of centers argued for radiotherapy, and also for grade 3, of course. But it was really a problem for other situations. For example, in this paper, it was presented a case with a grade 2 meningioma, incomplete surgery, first line presented in a non-critical location, a small volume, but a high proliferance rate of the meningioma. So you see, there were exactly 6 different techniques proposed by our radiation oncologist colleagues for the same case. It was from 1 fraction with radiosurgery to a maximum of 33 fractions of 1.8 during 6 weeks. So it was really a fact that we have no consensus in very, very few situations. So eluding the question of proton therapy, because for these centers, photon therapy was mostly preferred. Some positive evidences: imaging is all for us, radiation oncologists, because we don't open the brain. Neurosurgeons are our best friends, and patients could benefit clinically from radiotherapy, either exclusively or after surgery, of course. Finally, we have new radiotherapy techniques, and it's a progress for patients. Okay, we are all okay that surgery is the reference in meningioma management. But we can offer some volumetric reduction if you take the time, for example, at 2 or 3 years. We can offer a very good local control at 5 to 10 years, up to and above 90%. And there is also clinical benefit, not so evident versus surgery, but there is some situation where there is a clinical benefit up to 50%, depending on the symptoms, but often, for example, early if there is a visual problem. We have also clinical toxicity, but they are now very limited with modern radiotherapy. That is modern radiotherapy in the 60s in Villejuif. You see 2 cobalt units with bed and fixed arm and just 1 beam here and here. Hopefully now it is not more modern. We have the CyberKnife, we have the Linux, we will have possibly the Zapix, and we have also dedicated Linux and the CyberKnife also. They are not gadgets. They have a very high dose gradient. They have a high precision, less than 1 millimeter, but they are tools. The very important question is indications. You know that the main thing is the artist and not these tools. Example, modern radiotherapy is not yet 3D conformal radiotherapy. We can use modulated radiotherapy with fixed arms in a VMAT technique as tomotherapy with many schemes, very different fractionation, from a very prudent, careful 1.8 to 2 grade fractions to radiosurgery in one fraction with gamma knife, CyberKnife. Okay, so very importantly, also in American centers, regularly it is proposed as proton therapy and the optimal IMPT, for example, in a conventional fractionation, as this one from IBA Constructor. It's a proton therapy unit. We have the Novalis, okay. We have the CyberKnife, okay. So it has very, very importantly to be used in some good indications. For example, here, in fact, there are metastases. It is not meningiomas, but we know that especially in meningiomatosis, we can have many multiple targets, and it's very comparable to this situation with many small targets, and you can treat this all in one session and with a very important and interesting dose gradient, only 3 grade, for example. The advantage of proton therapy, you see that the photon therapy decreases very slowly the energy deposited on the tissue versus the proton therapy, where you can manage the deposit of radiotherapy of energy at a very precise situation. So, for example, from the left to the right, you have a proton therapy dosimetry and photon therapy with a VMAT technique, for example, and you see that all the low dose in the normal brace are deposed here and not here. You have here the subtraction of this dosimetry with photons versus the proton therapy, especially in young patients, but also at the extreme age for older patients. It could be very interesting to propose proton therapy if you have the availability. For example, here, protons, they are very optimal because the dose gradient, the tumor is very centrally located, and you can spare, of course, the temporal lobes, but also the hippocampi, and it could be, for the long term, very interesting in terms of memory conservation. Optimal fractionation for stereotactic radiotherapy, we have to deal with an efficacy on toxicity ratio. You see at the right a gamma knife machine, and it is the largest experience, of course, but with the time, with CyberKnife, we have not a comparable, but very challenging experience also for small residual tumor. You just have to know, and we know that with time, for example, at 3 years, there are some radionecrosis, even with gamma knife. So we can fractionate. So the name is hypofractionated stereotactic radiotherapy, a very long name, but you can fractionate the radiotherapy, especially if it is very near from optic apparatus, for example, less than 3 millimeters. There are possibly less radiation adverse events, but no randomized trial to prove it definitively. So another form of delivery is to deliver 5 fractions in a week. And it is possibly interesting in intermediate to large meningioma to be radiated, for example, for larger volume. What are our limits? It's difficult for radiotherapy to convince patients about the non-toxicity of our discipline, because these are benign tumors, so the patients are long survivors. There is no plateau for our radiation-late toxicity, and we all know that, especially if you deliver only radiotherapy in grade 2 and especially in grade 3 meningiomas, the very aggressive minimal part of meningiomas, there are up to 30% of failures at 5 years. Our limits are, if you have delivered one radiotherapy scheme, it is very rare to re-irradiate, especially in very large volume. So we have anti-angiogenic drugs. Trabectedin, for example, was tested in an AORTC prospective randomized trial, and there was toxicity with this drug and no signal on efficacy. There are other non-radiotherapy, non-surgical options for resistant meningiomas, but they are very rare and the signal are low. So targeted drugs also are very rare because less than 5% of these meningiomas are targetables. For example, a very old woman, but really fit, since several years described a blurred right vision. So this is a very big meningioma, you see that? The resection was proposed to this patient, 84 years old, I remember. It was like risky, said the surgeon, and the patient declined the proposition for surgery, and she asked for a second advice. We all see that it is very near from the optic nerve, very near from the brainstem also, and very large, especially compressing the chiasm, optic chiasm. So it was slowly progressing. So for us, it was a good indication for external radiation therapy as IMRT with photon or proton. The minimal dose was 50 gray with very careful dose per fraction. The patient received detailed info on all the acute and long-term radiotoxicities. She accepted that, so we delivered the radiotherapy in this very large volume. A very interesting point is that even in the 3 months interval, you see at the left the June MRI at the moment of radiotherapy decision, and in September, so just 3 months after, it was not stable at all. It was slowly progressing. So just before the radiotherapy, we have to remake the dosimetry because it was not so stable as previously planned. So you see the very classical dosimetry plan for this tumor, homogeneously delivered. And you see also the right lacrimal gland who was spared by this radiotherapy. And it was non-valistates, for example. It was a linac dedicated for this type of a great tumor, but with a high precision. And you see, for example, the right cochlea was partially spared, and the median dose was around 45 gray. So it is tolerable in terms of late toxicities. The right hippocampus also was spared with a minimum of 10 gray median dose. So it is possible to spare all the hippocampi with this type of modulated radiotherapy. Another case, a 66-year-old cardiologist with a follow-up only during more than 3 years. So no surgeon proposed him surgery, and finally he accepted radiotherapy with a good hippocampal sparing, and the right visual acuity was at the beginning of the disease 8, then 4, and when the right visual acuity was as 1, the patient was okay for a therapeutic proposal, and the therapeutic proposal was radiotherapy. So it is the images in 2012, and 2 years after, it has growth. So at the end, he accepted the radiotherapy. He had great fatigue during 1 year after the radiotherapy, but no other radiation adverse event. And the right vision partially recovered to 3, from 1 to 3. Interesting point, the volumetric regression continued even after 3 years. You see at the left at the beginning of the radiotherapy, and 3 years after, it has decreased from 4 millimeters. So it's not astonishing at all for us. For example, at 5 years, the meningioma continues to regress, and in a heterogeneous way. Third case, a 66-year-old resected twice from a grade 1 meningioma. And since more than 10 years, he was followed up every year, and at the end, it has increased. For example, here, you see the complete loss of left vision. Then the right vision gradually blurred also because of the progression of this meningioma. And the surgeon who was advised said no place for surgery, but he stopped this, the answer at this point. He didn't mention the place of radiotherapy. So it's a pity because at the end, the meningioma growth, and it was very dangerous for his right vision, gradually blurring. So we propose radiotherapy also. Important point, interesting point, to better delineate the meningioma, it was suggested that some PET tracer could be very useful to better visualize and delineate some very small parts of meningioma. So, for example, here, it is a second location from the main location, and it was not so easily visible with only the MRI, even with T1 gadolinium. Another very interesting meningioma, very heterogeneous one, the active part is illustrated here as easily more useful for delineation of radiotherapy. This tumor progression with a detailed vision checkup just before radiotherapy, and we deliver IMRT with a very careful 51 gray, and at the end, because of that, we can carefully spare the retina under 50 gray and the lacrimal gland under 15 gray. The patient was controlled and not progressing at 4 years on the follow-up. The last case, which was a very interesting one also, and we have to be careful about this atypical presentation. It was a rapid progression of a grade 2 meningioma after 2 macroscopically complete resection. So at this moment, you see the regrowth after 2 complete resection. It's really a very aggressive one. You see the images. At the left, just pre-radiotherapy, this is the very large volume after 2 resection, and we deliver the maximum of radiotherapy possible in terms of maximum dose, and it's astonishing, at 3 months, the meningioma regressed very, very rapidly. So it was also very atypical. So the patient was carefully followed every 4 to 6 months, and at the end, he regrowth 1 year after another time. So he was reoperated a 3rd time. You see the pre-op and the post-op images. At the end, it was possible to propose a second re-radiation. But 6 months after this second operation, there was a little, very, very progressing, but very little residual tumor, and he was re-irradiated, but with CyberKnife as a radiation, as a radiosurgery possibility. We have all to know that it was not really a meningioma. It was a hemangioblastoma at the review of the lecture, solitary fibrous tumor. So finally, how and when we do radiotherapy? We do radiotherapy in progressive or recurrence grade 1 after eventually reoperation if there is a residual non-reoperable tissue. We propose also for grade 2 and 3 if residual disease or progressive one, and regularly up to 60 grade for recurrent grade 2 and 3 meningioma, even after complete resection. We discuss in a polydisciplinary team for grade 2 meningioma as adjuvant therapy, even if complete resection, but after a deep discussion with the surgeon, because he knows the disease, he knows the extension, and we have also to have a complete exam, even a review of the pathology report, and a detailed review of pre-op versus post-op MRI. So finally, my only take-home message is, don't forget the role of modern radiotherapy. Even in stable or very large meningiomas, there is place for radiotherapy, even for old patients but fit. Even after a full dose of previous radiotherapy, we can re-radiate. We have to consider the symptoms also. We have to take our time to discuss, especially in a multidisciplinary staff. Muchas gracias por su atención.